Hello, it's Dr. Forskazazi, and welcome to part 3 of Embryology Made Easy, a crash course for medical students. Today, we'll be discussing the organogenesis of the mesoderm-derived heart and kidney tissue. We'll also briefly cover the role of the Y chromosome in sexual differentiation of the internal and external genitalia. When learning organogenesis, it is key to recall the organs through their primary germ layer origin. This is very commonly assessed in exams during the multiple choice questions and also in the anatomy steeplechase. A candidate will typically be asked to identify the primary germ layer origin of a structure within the human body, and so I implore you to take a bit of time to learn the structures within this table. You'll recall from part 1, when we were discussing folding, that the human can be considered a tube within a tube, with an innermost layer of endoderm and an external layer of ectoderm. You recall that the innermost tube can be likened and will form the gastrointestinal tube, running from the mouth to the anus. And as such, you can crudely remember that the endoderm-derived structures are those that are either part of the gastrointestinal tract or connect to it. This includes the hepatobiliary system and the pancreas that adjoin the GI tract at the duodenum. It also includes the respiratory tract that adjoins the gastrointestinal tract at the upper level of the esophagus, and the surrounding organs of the respiratory system, the thyroid, the parathyroid, and the thymus glands. The ectoderm, we discussed in part 2, forms our central nervous system, specifically the heart and brain. But this actually extends to all other parts of nervous tissue. The sympathetic nerves, the parasympathetics, and the enteric nervous system are all included in ectoderm-derived tissues, as is the autonomic nervous system. Now, the neural crest cells that form multiple structures, some which we'll discuss in this session, will go on to form the enteric nervous plexus, but not the sympathetics, autonomic or parasympathetic nervous system. We discussed briefly how the ectoderm forms the epidermis of the skin, but not the dermal layer. We also, through segmentation, understood how the somites will form the axial skeleton and the limbs, particularly the bony tissues and the skeletal muscle. Now, in order to expand this knowledge, we go back to this concept of tube within a tube. So we've said how the GI tract and its associated structures are formed by endoderm, and that the skin, the external layer, is formed by the ectoderm. Now, if a viscera or organ exists between these two layers, the best bet is that it is mesoderm-derived. And this includes things such as the heart, the kidneys, and the gonads, as they lie between the skin and the gastrointestinal tract, but are not directly in contact with the GI tract. This also includes the spleen and the two input and outflow aspects of the splenic system, the blood and the vascular system, and also the lymphatics. Now, when trying to figure out the other functions and derivatives of the ectodermal layer, one can remember it as the organs and receptors used either as part of the nervous system or in the special sensors. And we'll run through the list to demonstrate this point. So we've already discussed how it forms all nervous tissue. However, in textbooks, the pituitary and the adrenals are sometimes considered, the adrenal medulla are sometimes considered extensions of the nervous system, particularly considering their role in the peripheral nervous system. Furthermore, the cornea and lens of the eye can be considered as part of the function to see. The epithelium of the oral and nasal cavities are involved in the senses of taste and smell. And actually, the tooth enamel was an evolutionary development to allow fish to sense the acidity and temperature of their surrounding water. For us, we may experience this when drinking a cold drink or eating a sour dessert. The melanocytes can be thought of as an extension of the epidermis as they sit in the epidermodermal junction. And finally, the cranial bones and branchial cartilages are best covered during head and neck anatomy. So we'll now go back to the mesoderm and discuss the first tissue here. So the formation of the heart is dependent on cardiac progenitor cells from the cranial third of the mesoderm. Hopefully you'll recall from the session on ventral folding that these are some of the most cranial cells in the trilaminar disc, and folding is required to bring them into the thoracic cavity. Now during this process they begin to migrate laterally, and they localize into two lateral plate mesoderms, the cardiac crescents. Now often in exams the specific region of mesoderm will also be assessed, so it's important to remember that this is the lateral plate mesoderm. These two cardiac crescents will coalesce and form a primitive heart tube that has a cranial outflow end and a caudal inflow end. This cardiac tube is lined by an endothelium equivalent to the endocardium, and also a mass of mesoderm that is very similar to the myocardium. And around day 22, it begins to contract. This rather old diagram here is very good at portraying the derivatives of each part of the cardiac tube. They are all actually very logical. If you consider the truncus arteriosus as the outflow end of the linear heart tube, it was obviously going to form the outflows of the ventricles, the ascending aorta, and the pulmonary trunk. The inflow, i.e. the venous end, is going to form our vena cava, our inferior vena cava, and our superior vena cava. If we consider their input into the heart and the significance of the size of the vena cava, it becomes obvious that the sinus venosus must also form part of the right atrium. Then, for the similarly named primitive ventricles and primitive atria, they will form parts of the right and left ventricles and atria respectively. Now, obviously this tube is too truncated and short in order to form a four-chamber heart, so it must elongate further in preparation for folding into a complex structure. Now, this primitive heart recruits additional cells from a secondary heart field, and around day 23, the linear tube forms a C shape, such that the right side of the tube becomes the outside curvature of the heart. Elongation at these arterial and venous ends of the pole are such that this C-shaped heart tube becomes S-shaped, which is more similar to that of a four-chamber heart as we know it, and further smaller movements are undergone in order to bring the outflow ends at the right aspect of the heart and the inflow end also. Around day 24, blood begins to circulate throughout this embryo. Now, this is related to, as we'll discuss in part 4, the formation of the liver, which actually acts as the first hematopoietic organ of the embryo. This is also important as between days 22 and 24, the fetal heartbeat will be detectable on ultrasound. This forms part of some groups' argument regarding personhood and relates to their understanding and beliefs surrounding abortion. Now, the folded heart tube remains unsegmented, and so septation needs to occur to divide it into the four chambers. The septum premium, literally meaning the first septa, will approach the septum intermedium, the middle septa, to create the ostium primum, the first hole of the heart. Now, the septum premium and intermedium will fuse, obliterating this ostium primum. But during the same time, the ostium secundum, the second hole, forms due to apoptosis at the cranial edge of the septum primum. And shortly thereafter, the septum secundum is going to grow from the roof of the right atrium, but does not quite interact and reach the septum intermedium. This will create the foramen ovale. So let's have a look at this in a diagrammatic form. Here you see the septum premium come down towards the septum intermedium, Forming this foramen premium, our ostium premium, the first hole. And as this joins the middle section of the heart, this first hole is obliterated, but we have development of the foramen or ostium secundum. And here we can see the septum secundum growing from the cranial aspect of the right atrium. But it doesn't quite reach the septum intermedium. And as such, there remains the foramen ovale. This tract between the right and left atria will then close shortly after birth. Now, the ventricles are separated much more simply through the development of a ventricular septum from the inferior heart. Then the outflow tract of the ventricles is divided by a spiral septum into the ascending aorta and the pulmonary trunk. In order to separate the atria from the ventricles, the endocardial cushions are penetrated by neural crest cells to form valves. The foramen ovale will remain patent in approximately 25% of the population. Its function in the embryo is to allow oxygenated blood to pass from the right side of the circulation into the left side of the circulation without needing to cross through the pulmonary vasculature. This is because the hemoglobin in the fetus is oxygenated through the mother and so has no requirement to pass through the lungs. Now, the foramen ovale will typically close at birth, as the infant will take its very first breath. That will widen and expand the lungs, and with that increase the diameter of the pulmonary vasculature and reduce the pressure in the pulmonary system. As such, blood will pass through the pulmonary vasculature and increase the return into the left atria and increase the pressure in that chamber, which will then close the foramen ovale. Now, if the septum secundum is too short and doesn't fuse with the septum intermedium, it may remain open. And this can present clinically through a paradoxical embolus. This occurs where a thrombus forms in the venous system, but then the embolism deposits in the arterial system. This occurs because the venous embolus will return to the right atrium, and whereas typically it would be filtered out through the pulmonary vasculature, it actually passes through a patent foramen ovale into the left atria and then is pumped through the systemic circulation by the left ventricle, depositing either at a limb or organ, leading to ischemia and possibly necrosis. Now, another mechanism by which the fetus bypasses the lungs is through the Ductus arteriosus. This is a connection between the pulmonary artery and the aorta. Now, its function again is so that the outflow of the right ventricle, rather than the right atrium, can bypass the lungs and pass this oxygenated blood straight into the left side systemic circulation. It usually closes after birth due to a decline in the placental prostaglandin E2 and due to bradykinin release from the lungs. This leaves behind a residual ligamentum arteriosum, and typically closure is completed by 3 weeks. However, if the ductus arteriosus remains patent, then there is shunting of blood from the aorta back to the pulmonary artery. This is because of the high pressures that are sustained within the aorta, typically 40 millimole up to 40 millimoles higher than the left ventricle, and as such blood returns from that systemic circulation into the much lower pressure pulmonary circulation. And this presents clinically through shortness of breath, tachycardia, and a continuous machine-like murmur. The shortness of breath is due to the increased volume of circulating blood in the pulmonary circulation, and as such, the edema that may result. It also could be the result of cardiomegaly and heart failure, as less blood is being pumped into the systemic circulation, so there is a backlog of blood in the pulmonary circulation as the heart is not efficiently pumping it through the left atria and the left ventricles. This condition may also result in tachycardia, as in order to maintain the cardiac output, the heart rate is increased. A continuous machine-like murmur can be auscultated on the chest. Murmurs occur where the laminar flow of a liquid, such as blood, is disturbed. As the blood passes from the aorta into the pulmonary artery, this turbulence of flow is heard as a continuous machine-like murmur. In order to treat a patent ductus arteriosus, one needs to decrease the prostaglandin levels pharmacologically, and this is done through non-steroidals, which will inhibit COX and as such reduce levels of prostaglandin. However, this connection between the pulmonary and systemic circulation is sometimes necessary to keep the infant alive. In some heart defects, such as transposition of the great vessels, this is the only way that oxygenated blood can enter the systemic circulation. These patients will present with cyanosis. However, they will do so several weeks after birth, as the duct begins to close. This is why things such as transposition of the great vessels are considered duct-dependent heart defects. While the duct remains patent, the fetus is well in itself. However, as it closes, there is a reduction in oxygenated hemoglobin passing through the systemic circulation, manifesting as cyanosis. Atrial septal defects can occur where there is malformation of the interatrial septum. The size of this defect will vary, as will the clinical manifestation as a result. Often, these are asymptomatic, as discussed previously with the patent Foramen Ovale. However, blood can move from the right atrium to the left atrium, leading to this paradoxical embolus, but also from the left atrium to the right atrium. Now, this is more typically seen in the ventricles through a condition known as Eisenmenger's syndrome. This is where a defect in the interatrial or interventricular septum means that blood is shunted from the left to the right and then is reversed from the right to the left. This occurs because as the higher pressure and more muscular left side of the heart pumps blood to the right side of the heart through the defect, over time the right side of the heart will hypertrophy in order to respond to the increased blood return. As this concentric hypertrophy occurs, the pressures inside the right side of the heart build up, and as they do, the flow can be reversed through this shunt such that blood will pump from the right side to the left side, and as a result, blood that has not passed through the lungs will begin to enter the systemic circulation through the shunt. This is known as Eisenmenger's syndrome and can be very lethal. It presents with cyanosis and dyspnea as the systemic circulation is now pumping deoxygenated blood. It can also lead to pulmonary hypertension as the much more hypertrophic and muscular right side of the heart is pumping at higher pressures than required through the pulmonary vasculature. When the defect is in the interventricular septum, it typically occurs at the more superior membranous aspect of the septum. This is because the inferior aspect of the chambers is through which the propulsion of contraction during systole occurs. Very commonly assessed is the Tetralogy of Fallot, as this is one of few causes of cyanosis at birth. Note here the distinction with the patent ductus arteriosus in duct-dependent circulations, as when this becomes no longer patent around week 3, then the fetus becomes cyanotic, whereas here the baby is presenting at birth with cyanosis. The four key features of the tetralogy of Fallot are a ventricular septal defect, pulmonary stenosis, right ventricular hypertrophy, and an overriding aorta. It is sometimes easy to remember these features as resultant effects. For example, the right ventricular hypertrophy will occur 1. Due to the ventricular septal defect, but also due to the pulmonary stenosis. Furthermore, the pulmonary outflow tract is narrowed because of an overriding aorta. Therefore, one can see how all four features of the tetralogy of Fallot are interlinked. Commonly, this is seen actually during the clinical presentation of DeGeorge syndrome, also known as the 22nd chromosome deletion syndrome. It occurs at the 11.2 locus of the long arm of the chromosome, at the Q arm, and can be remembered by the mnemonic catch-22. Presents with a cardiac abnormality, such as a tetralogy of Fallot or an interrupted aortic arch. The baby has abnormal facies, thymic aplasia, a cleft palate, or hypocalcemia/hypoparathyroidism. Another clinical manifestation of incorrect heart folding is dextrocardia. You'll recall during the session on gastrulation that we discussed the importance of the formation of the right-left axes, where the right-left imaging of the heart is incorrect solely in the heart. This is known as dextrocardia situs inversus. However, when it occurs as part of a wider condition in the whole body, it's known as dextrocardia situs inversus totalis. When we were discussing the formation of the right-left axes, we mentioned the importance of cilia that waft molecules in a clockwise fashion. Where there are issues with these cilia in a primary ciliary dyskinesia, such as in Cartagener's syndrome, then the right-left axes of the body is disrupted and can often be mirrored. Now we will move on to organogenesis of the kidneys. Whereas previously we were discussing the lateral plate mesoderm, we now move on to discussing the intermediate mesoderm. And this is going to form our nephric structures, such as our suprarenal glands, our adrenal glands, specifically the cortex, because as you remember, the adrenal medulla is a derivative of the ectoderm. The intermediate mesoderm will also form our gonads and our genital ducts. Very interestingly, during organogenesis of the kidneys, we see the three evolutionary structures that one can see in fish and mammals. The pronephros is a feature of fish, the mesonephros is a feature of lower vertebrates, and the metanephros is seen in higher vertebrates. The pronephros is this less differentiated and specialized kidney-like system. The mesonephros gains function for the excretion of toxins and exchange of ions, and then the mature metanephric structure allows efficient exchange at the kidney level. The pronephros begins to form early during the 4th week. An epithelialization of this intermediate mesoderm at a cervical level will form the mesonephric and mesonephric/Wolffian ducts. These are solid rods that will begin to grow caudally towards the pelvic area. Ventromedial to these rods, further mesoderm condenses and reorganizes into epithelial buds. These buds will attach to the rod and hollow out to become the pronephros, as seen here. This very crude kidney-like structure allows for the transfer of toxins and also ions from this blood system into the kidneys. However, this is far too insufficient for any more complex animal, and so the development of the mesonephros occurs. Here, the Wolffian/mesonephric ducts induce the formation of tubules from the more caudal intermediate mesoderm, as you can see here. Around 40 of these tubules are going to form, of which 20 will obliterate, leaving the most caudal 20. And these begin to differentiate into a more specialized excretory unit with a bundled capillary to increase surface area and a better receptive excretory unit to maximize the transfer of ions and molecules. This is actually a functional structure in the fetus between weeks 6 and 10. Now, very commonly assessed and important to remember is that the mesonephric/Wolffian ducts completely regress in females. You need to come up with a simple way to remember this, and one tool I've used is to play on the patriarchal and masculine features often associated with animals such as wolves, and to think of the Wolffian duct as remaining in the males and completely regressing in the females. The metanephros begins to develop around the 5th week and forms more caudally to the mesonephros. This will be our permanent and functional kidney in the higher vertebrates. It is formed of 2 components, a collecting component for the urine, formed from the ureteric bud, and an excretory metanephric blastema. Here we can see much more specialized functions that we can see in the adult kidney. There is a collecting system that focuses on transferring the urine from the kidney to the bladder, and then a metanephric excretory system that works for ion exchange and secretion of toxins. This collecting component will form the ureter, the renal pelvis, and the major and minor calyces. These are areas where very little exchange of molecules occurs. And it will also form the collecting ducts and tubules, where some water reabsorption happens, but not much in the way of exchange of ions and reabsorption. The metanephric blastema is where the significant role of the kidneys in homeostasis can be seen, through the excretion at the Bowman's capsules, the reabsorption and exchange at the proximal tubules, the loop of Henle, and the distal convoluted tubule. Here you can see this ureteric bud growing into a metanephric blastema. This bud will continue to bifurcate and will do so 20 times, leading to millions of nephrons. This is due to the logarithmic multiplication that occurs. Around the 10th week, the distal convoluted tubule of the metanephric excretory system will connect to the collecting ducts. In the fetus, the function of the kidneys is not to excrete waste, but to add amniotic fluid. As you'll recall, obviously the exchange of toxins occurs at the placenta and not through the kidneys. The function of the kidneys is to add to the amniotic fluid to both increase the physical barrier between the fetus and the abdominal cavity / environment, but also to allow the fetus to begin to practice for life outside the womb. And by this I mean the amniotic fluid is key to lung development. When you consider the first breath being one of the most important things that a fetus must be able to do the moment it is ex utero, it becomes logical that the fetus would practice the motion of breathing in utero. And as it does so, it breathes in amniotic fluid and breathes it out. This allows it to gain strength in its intercostal and diaphragmatic muscles, but also the flow of amniotic fluid through the primitive lung tissue allows it to mature and differentiate. Clinically, if there is an issue with the development of the kidneys, this may be seen as a horseshoe kidney, where there is fusion at the anterior and inferior poles of the kidney, and this may lead to obstruction over the vessels of the aorta and the IVC. However, much more commonly, any patient with an abnormality of the kidney will present with increased UTIs. This can be seen in patients that have ectopic or additional ureters. For any patient clinically that presents with a UTI that is atypical, for example due to their age, such as young children, or in males, particularly those that are below the age of 65, or any individual that has repetitive urinary tract infections without an identified cause, it is important for the doctor to organize an ultrasound scan of the kidney and urinary tract and the bladder in order to assess for any defects or embryological consequences / malformations that make the patient more susceptible to urinary tract infections. Finally, agenesis of the kidneys can occur either on one side or both. This leads to a lack of amniotic fluid. The consequence of this will be seen through lung development, but also through development of the skull vault and the face, as there is no longer a fluid barrier between the face and the abdominal cavity. As such, this may present with facial abnormalities as a result of the face pressing against the abdominal cavity. So, in the baby, one might see flattening of the skull vault. Now, when considering the mammalian gonads, they are unique. They remain bipotential between weeks 4 and week 7. Paired regions of intermediate mesoderm adjacent to the kidney will begin to form the Müllerian ducts, just lateral to the mesonephric ducts. The SRY gene, the specific region of the Y chromosome gene, will lead to male characteristics. It does so through promoting the secretion of anti-Müllerian hormone by the Sertoli cells, and also the production of testosterone by the Leydig cells. Here, there is a twofold mechanism to encourage the formation of male internal and external genitalia. The anti-Müllerian hormone causes the Müllerian ducts to regress between weeks 8 and 10, and the testosterone sustains the mesonephric / Wolffian ducts. Females, however, lack the SRY gene as they lack a Y chromosome, and therefore they do not secrete anti-Müllerian hormone. In females, the Müllerian ducts will persist and go on to form the fallopian tube, the uterus, and the upper vagina. A lack of testosterone leads to a regression of the mesonephric ducts. That concludes part 3 of the course, and I look forward to teaching you more during part 4.